This video is to explain the use of the Patient Education CD. This has been newly updated for 2013 with some new features. I'll go through the basics of how you use it, and I'll show you the new features which are very important, and you should be able to do this in a very short time, maybe 10 minutes, and if parents want a full explanation, it should be never any more than half an hour to explain everything about myofunctional orthodontics. So let's get started. So when the patient and parent first come in, you want to know exactly what they're here for, what information they need to find out, and there may be some specific questions that they need answered before you even start. So you're prompted here, what's the reason for your consultation? You're concerned about crowded teeth, you don't want braces, don't want extractions. What do you see already in your child? What particular areas have you seen already? So we need to know the level of education of the parent already, and quite often they'll know quite a bit because they've already looked at the mybrace.com website, which will explain pretty much everything about myofunctional orthodontics. So if you ask them if they've seen this already, that means you can fast track straight into being very specific about the treatment planning. And what do you want for your child? Don't want braces, don't want extractions, want better facial development. And so answer anything that's specific, and then you get started by pressing the start button. This will go to the introductory video. Now, you ask the parent, have they seen this already? If they haven't, you play the whole lot, go out of the room and let them hear the whole video. Many times they've already seen it because it's on the mybrace.com website. So in which case you would skip over that and go straight to getting to be more specific about malocclusion. Now, we know 3 out of 4 children have a malocclusion. And the problem is that braces don't really resolve the issue. Put the braces on, braces come off, unless the retainers are on pretty much for a lifetime, the teeth will relapse again. Main reason is the tongue and the lips, the real culprits of causing the malocclusion, have never been treated. So the tongue has a force of 500 grams, the lips have a force of 1 to 300 grams, and you can ask the parents, do they know how much force you need to remove a tooth? And that's only 1.7 grams, so clearly the tongue and the lips are going to decide the tooth position. The problem with regular orthodontics is there are a whole bunch of downsides that after 50 years we realise that it's not really the way to go. Enamel damage is clear. If you don't clean your teeth properly, you're going to get white spots, and also when the brackets come off, they do damage the enamel. Root damage occurs in nearly all cases according to current research. Relapse occurs also in most cases, and now just about all orthodontic treatment plans are saying you need to retain forever. And we won't want to do that. We want to look at the causes. The causes are mouth breathing and incorrect swallowing. And this affects the way the jaws grow. So at normal growth develops like this, downwards and forwards growth. If you're a mouth breather, the growth is down and back, so there's not enough space for the front teeth nor the erupting wisdom teeth, and this is why you get crowding of the front teeth and you need to have wisdom teeth out. This is the amount of lack of forward development that you get because of mouth breathing. So clearly, if we can get the child to breathe through the nose, there'll be plenty of room for the teeth. Same thing with reverse swallowing. Every time a child swallows, which is twice a minute, if they have a reverse swallow, they'll be pushing back against the direction of growth. That will be causing lack of forward development of the jaws, which will give less room for the front teeth, and again, less room for the erupting third molars or wisdom teeth. In addition to that, this reverse swallowing pattern pushes back on the jaw, and the jaw joint gets compressed, and this is where we get TMJ disorder. And many children will show the signs of TMJ disorder already, even at a young age. So poor myofunctional habits affect forward growth of the upper and lower jaws, and we want to correct that as soon as we see it. And the earlier the better, because we want the direction of growth to go correctly. If we start looking at the swallowing patterns, you'll see that children swallow with this reverse swallow, which pushes back against the direction of the growth, and then you can refer that directly to the patient, and you can show the parent that that habit is exhibited in their child. So the correct tongue position is up in the upper jaw, where it is responsible for correctly developing the upper jaw, and when the upper jaw is developed correctly, the lower jaw follows, and there's plenty of room for the teeth. And if we look at our trainer and myobrace system, they're designed to guide the tongue up into the correct position and also make the child breathe through their nose. The importance of getting the child to breathe through their nose is illustrated here. If you're breathing through your mouth, the air is not filtered and you are prone to getting lots of infections. And in addition to that, the upper and lower jaws will not grow correctly. And there are obviously other health problems from breathing through the mouth. So the cause of crooked teeth is lack of the tongue being up into the upper jaw because of varying habits. And that's what we want to achieve with our treatment. We want to get the tongue functioning correctly in the upper jaw. How do we do it? We have a range of appliances called myofunctional orthodontic appliances, which are primarily the myobrace, and there are various ones for various stages of the child's development. How do the myobraces work? 4 things: habit correction, arch development, tooth alignment, getting the teeth finally into the correct position, and retention. But in fact, all the way through the treatment, we're assisting habit correction because that's the primary goal of the treatment. The only real retainer that we want to use is good function, and when we have good function, the teeth will remain in their corrected position. And we always say what we want to do is get good growth and development, and we want the teeth to come into their natural position. We're not artificially putting the teeth into a position of straightness like braces are. We're trying to get the children to develop correctly and have the teeth to come into their natural position. We use various appliances for expanding the upper jaw, not so much to fit the teeth in, but mainly to get the tongue in the correct position. And quite often the upper jaw is too narrow, and we need to put in an appliance to correct the shape of the upper jaw. The problem with these older Bioblock appliances or acrylic appliances, they get in the way of the tongue, so we want to use the bent wire system, which does not encroach on tongue space, and in addition it uses the force of the tongue to expand the upper jaw. Remember, the tongue's got a force of 500 grams. If we can encourage the tongue to go up and help us expand the upper jaw, we'll not only get a better result, it'll be much more stable. So we combine the bent wire system with the myobrace system, and that helps to get the tongue up in there, and the tongue is a big helper in getting the correct upper arch form. Once we have the correct upper arch form, there's plenty of room for the teeth, and we can align them with very light forces. Sometimes we have additional appliances where the children cannot get their lips together because they don't have enough lip strength, and so we use a lip trainer. In addition to that, we have the myelate, which is composite filling material that's put on the back teeth to guide the jaws into the corrected position for class 2, class 3 and crossbite. Appliance selector is very useful when we select the patient's age or level of development. We can show the parents there are a series of appliances that we need to use to correct not only the function but also the jaw position and then the final alignment. In addition, we have trainer activities or MyBrace activities which the child has to do every day. This is very much a child's cooperation because we need them to change their habits. It's their problem and it's their solution. So children have to do breathing exercises, tongue lip exercises every day, and wear obviously their MyBrace every day. These exercises are all on DVD, and not only can the child look at them when they're in the clinic, they can also access them via the web, so they can very easily do their daily exercises.
Resting position.
Patient compliance is important. If children don't wear the appliances correctly, have regular visits to the clinic and do their activities, the treatment won't work, and you have to be very specific to parents that it will not work unless you get good patient cooperation. And you need to get this down to a child level. If the child understands it, they'll do it. If they don't, you won't get cooperation. We never say that we don't need to have braces, particularly if we don't get good compliance. We always factor in possibly using braces for a short period of time. The better the compliance, the less need there is for braces. And success of the treatment is really based on compliance. Better compliance, a better outcome. So these are our goals. We go through it. The child must be breathing through the nose at all times. They also must have the lips together at rest with the correct tongue position. These three things really give us the following points, which is no mentalis activity, no pushing back with a reverse swallow on the teeth. That will give us good facial development, correct class 1 occlusion, and notice number 7 is straight teeth. It's not our priority, but it's the result of all these other things. And we want to, if possible, not use retainers. Not always possible, but that's the goal. And this is what the child has to do. They have to wear the MyBrace 1 hour a day plus overnight while sleeping. Every day, has to be every day, otherwise it won't work. The MyBrace needs to stay in at night. If it doesn't stay in at night, we need to do additional breathing exercises to make sure they are breathing through their nose at night. They have to do at least one MyBrace activity each day. We want the mouth closed at all times during when they don't have the MyBrace in, so they have to keep their lips together. It's a training process. The tongue resting in the upper jaw all times. We have to see them at least monthly, oftentimes a little bit more often if the compliance is not good. And we want to have them on a hard diet with good nutrition. Each time the patient comes in, we also show them a small additional exercise on diet and nutrition, which is directed toward both tooth decay and growth and development. This is our new patient evaluation. I'll go through this quickly. We work from the dental alignment. We're talking about orthodontic treatment, but we work back from that, from dental alignment, arch form, that gives us the correct or incorrect occlusion. Then we evaluate tongue position, lips and swallowing, motor breathing, is it mouth or nose, facial development, posture and TMJ dysfunction. Now, if the auxiliary person is doing the first consult, they just give an overview here. If the dentist or the therapist at this stage comes in, they can do a full evaluation which is based on these points, and then we can explain each of these to the parent, what tongue position is all about, why it's important to have the lips together, and evaluating their child's swallowing pattern. Clearly motor breathing, if the mouth is open all the time, we have a problem and we need to correct that. These things are all related to craniofacial development, so you'll see many of these children are severely underdeveloped because they have all these habits restricting the natural growth. So we want the jaws to grow naturally, and we want the teeth to come into their natural position. So we're really wanting the child to grow to their genetic potential, and it's important to understand that really we're not importing something that shouldn't be there already. It's allowing the child to grow to their full genetic potential without these habits holding them back. We look at posture, particularly with mouth breathing. Patients, they have often a low shoulder and a forward head posture, and we do a TMJ evaluation, a basic evaluation. Many of these children already have a TMJ disorder. At this stage, you stop and say, right, there are two things we can do here. We can just give you some of the information which is enclosed here, or we can evaluate your child further by taking records, study models, photos and x-rays. Many parents will want to know what the fees are. These are also enclosed in the patient handout, and then we can go through the fees and say approximately how much it's going to be, but we use the records to do an accurate and personalised treatment plan, and then next time we can give the parent an accurate assessment of the treatment costs. If they want to see a similar case, we have cases in the proven results section, and depending on the age of the patient, we can show them early mixed dentition. We can show them more complex cases with a bent wire system. So that's the explanation of the new Patient Education CD. It's a quick overview. I urge you to go through it and make sure you can do this very confidently and present all the information in here directly to the parent and the patient.